Welcome everybody to the SSBMT webinar series. My name is Dr. Riyad Dada. I am happy today to moderate this very interesting talk today, sponsored by Kiona Kirin. And we have today a distinguished speaker who is Professor Pier Luigi Zinzani. He is a world-known professor on lymphoma. He's a full professor of hematology at the University of Bologna. Served as a principal investigator for around 200 clinical trials. He was former president of the Italian Foundation on Lymphoma, the known PhIL group, which produced quite interesting number of practice-changing trials. And he is currently a member of the board of directions. He has authored over 580 peer-reviewed papers in very highly respected and regarded journals like New England Journal of Medicine, Blood, GCO, and so on. Professor Zinzani today will give us some insight around how he is treating cutaneous T-cell lymphoma. Professor Zinzani, please.
Thank you very much, Professor Dada, for your kind introduction. Good evening to everybody. In the next 25 minutes, I will do an update concerning the treatment of CTCL, cutaneous T-cell lymphoma. And I think it's very important to discuss concerning the guideline, in particular in this case, the European guideline from ERTC in the treatment of cutaneous T-cell lymphoma. As you know, mycosis fungoides and Sézary syndrome represent at least 80% of all cutaneous T-cell lymphoma. And you can see here in this update by RTC on 2017, which is the treatment in a front line. So according to the different stage of the disease. And you can observe that there are several possibilities in the same stage. For example, stage 1A, you can have watch and wait or topical steroids, phototherapy or local radiotherapy. The same situation for 2B and also for 1B. For 2A, you can have again the option, the therapeutic option of topical steroids, phototherapy, or local radiotherapy. And the same situation is also for advanced stage, like stage 3 and the Sézary syndrome, because as you know, in this case, there are several therapeutic options, and the decision is patient by patient according to this kind of range of therapeutical procedure, like total skin irradiation, interferon, bexarotene, monochemotherapy, methotrexate, polychemotherapy, and also the extracorporeal pheresis. And the same situation is concerning the second line. By RTC, again, there are several possibilities in the same different stage of the disease during the second relapse and third relapse. And this is the situation in terms of treatment, in particular stage-based treatment by RTC. And you can stratify the patient in early stage or late stage, in this case including only mycosis fungoides. And you can see the several therapeutic options, as I said before, concerning the stratification according to the early versus late stage. Another important concept in the treatment of cutaneous T-cell lymphoma is the treatment upgrading. You can start with steroids plus EVB, and then you can move to retinoids plus PUVA, and then total skin irradiation or conventional chemoimmunotherapy until the extracorporeal photophoresis. And at the same time, you can have also the downgrading in the same patient, because sometimes you can move from wait and see topical steroids, total skin irradiation, and also the treatment with PUVA plus bexarotene. Because the disease is up and down, it's so difficult to think to cure this kind of patient. The most important point is to try to prolong the overall survival, and you can have some patients that did several kind of therapeutic option, but they are still alive after 15, 20 years. And this is the concept, the paradigm of the re-challenge paradigm, moving from PUVA, topical steroid, PUVA again, total skin irradiation, and conventional chemotherapy like gemcitabine. And another important concept in the blood classification is recently inside some international retrospective prospective study, we observed that most patients with early stage, like stage 1A, stage 2A, mycosis fungoides are B0, but B1 may be seen in around 1 in 5 early stage patients. And the larger retrospective analysis of more than 1,500 patients with mycosis fungoides or Sézary syndrome found significant reduction in both overall survival and disease-specific survival with increased B stage. So the same study also found a higher risk of disease progression in patients with B1 disease compared to those with the B0 disease. I think it could be very important in the future to try to stratify in the better evidence B1 versus B0 patients. And now we move to the new therapeutical approach. And in the last few years, finally, there was the possibility to have also 2 huge phase 3 randomized trials in this really rare disease like cutaneous T-cell lymphoma. The first one was the Alcanza study, and this was the Alcanza study, it was a phase 3 randomized trial, brentuximab vedotin, randomized and comparing brentuximab vedotin, an anti-CD30 drug-conjugated monoclonal antibody, versus the physician choice, in particular bexarotene or methotrexate, in an international phase 3 study. I was involved in this trial, and you can see here the study design, including mycosis fungoides, all relapsed refractory patients with a CD30 expression at least 10% or more, and also few patients with primary relapse or primary refractory primary cutaneous anaplastic large cell lymphoma. And the random was 1-to-1, comparing the classical dose and schedule of brentuximab vedotin versus the physician's choice, methotrexate or bexarotene. And in this study, the primary endpoint was the overall response rate at 4 months or more. Was a particular selection of the primary endpoint with a picture after 4 months and to follow this kind of overall response rate. Another one was the independent review of a global response of all compartments using consensus guidelines as set by SWOT, I mean the skin evaluation, radiographic assessment, and also, of course, the circulating Sézary cell assessment. The secondary endpoint were CR rate, progression-free survival, and also the quality of life. And these are the patient characteristics. 64 patients for each arm were included and randomized in each trial. All the patients were well matched according to the different characteristics. Also, in particular, for the total number of prior treatment, the median was 4 for brentuximab vedotin, was 3.5 for the investigator choice. So I mean methotrexate or bexarotene. And you can see here that the number of primary cutaneous anaplastic large cell lymphoma were 16 in the brentuximab vedotin and 15 in the standard arm. This is a real rare disease, versus 48 patients with mycosis fungoides in the brentuximab vedotin arm versus 49 in the methotrexate or bexarotene arm. And the primary endpoint, the overall response rate after 4 months, at least 4 months and more, was 56% for brentuximab vedotin versus only 12.5 for the investigator choice, and of course the P was statistically significant. In terms of secondary endpoint, the CR rate was 15.6% for brentuximab versus only less than 2% for the investigator choice, and again the P was statistically significant. The median progression-free survival was roughly 17 months for brentuximab vedotin versus 3.5 months for the investigator choice. And also the mean maximum reduction in the Skindex 29 symptoms domain points was minus 28 versus minus 8, and this was again statistically significant. And you can see here the overall response rate for and response rate by disease stage. And you can see that in the brentuximab arm, the overall response rate was absolutely superior in all different stages, from stage 1A until the advanced stage 4B for mycosis fungoides, and the same situation also for the primary cutaneous anaplastic. And this is a confirmation that the real activity of brentuximab vedotin as a single agent in all the different stages of the disease. And this is the waterfall plot according to the two different situations. So for brentuximab vedotin in mycosis fungoide and in primary cutaneous anaplastic versus the same situation for the investigator choice, I mean methotrexate or bexarotene. And another important point, the progression-free survival, the median progression-free survival, as I said before, is close to 17 months for brentuximab vedotin and no more than 4 months for the investigator choice. Again, the P was statistically significant, with a difference at least of more than 1 year. In terms of safety profile, of course, the peripheral neurological toxicity was the most important side effects in the brentuximab vedotin arm, and as usual, grade 3 and 4 are really low, but the most part of the patient present grade 1 and 2 is reversible, the most part of the patient. And another important toxicity for the investigator choice arm was the hyperglycemia, in particular for patients treated with bexarotene. And so the toxicity is very peculiar according to the different kind of treatment. The second huge trial was the Marlborough trial. It was a phase 3 international study comparing in a random 1-to-1 mogamulizumab, an anti-CCR4 monoclonal antibody, versus vorinostat, an HDAC inhibitor, in pre-treated patients with cutaneous T-cell lymphoma, including mycosis fungoides and also Sézary syndrome. Also in this trial was involved, included more than 20 patients. You can see here, mogamulizumab is, as I said before, is an anti-CCR4 and is overexpressed the CCR4 antigen in peripheral T-cell lymphoma, cutaneous lymphoma, and also in ATL. And it's present in higher ADCC to this particular technique called Potelligent. And this is the study design, and you can see that the patient included were mycosis fungoides or Sézary syndrome from stage 1B to stage 4B with at least one prior course of systemic treatment. And of course, we excluded the patient with large cell transformation. I mean, this new rare entity called transformed mycosis fungoides. The random was 1:1. Moga has the conventional dose of 1.0 milligram per kilogram intravenous. Day 1, 15, weekly for the first cycle, and then every 2 weeks for the subsequent cycle. And vorinostat, the conventional dose of 400 milligram per os daily until the progression. We included 372 patients in among 59 centers around 11 countries. All the treatment was administered in an outpatient clinic, and vorinostat was administered in accordance with American prescriber information, because we know that there is no official indication of vorinostat in Europe, also in other continents like Asia. And this was particularly studied because there was inclusion also the crossover, a one-way crossover from vorinostat to Moga after progression disease or some toxicity. Primary endpoint of the study was a progression-free survival based on investigator assessment, and the key secondary endpoint were overall response rate, duration of response, the safety, the overall response rate of patients in the crossover population, and also the quality of life. In terms of patient characteristics, we included 186 patients for each different arm without any kind of significant difference in all the baseline characteristics. And you can see the median age was quite the same, 63 for Morgan, and vorinostat for vorinostat was 65. The median number of prior treatment was 3 for Montgomery Zuma, ranging between 1 to 18, and was 3 for vorinostat, ranging from 0 to 14. And this was the primary endpoint. The progression-free survival was close to 8 months for Montgomery Zuma versus only 3.1 months for vorinostat. Of course, the P was statistically significant. In terms of clinical response, the overall response rate was 28% for Moga versus 5% for vorinostat. And in particular, for mycosis fungoides, the overall response rate was 21% versus 7%, and for Sézary syndrome was 37% versus 2%. The median duration of the response was 14 months for Montgomery Zuma versus 9 months for vorinostat. And in particular was 13 versus 9 months in mycosis fungoides setting, and 17 versus 7 months in the Sézary syndrome. The overall response rate using mogamulizumab after crossover from vorinostat was 30%. And the clinical activity by compartment, this is another important concept. So the real activity of mogamulizumab on the skin, on the blood, on the lymph node, on the viscera. So in the skin, the overall response rate was 42% for mogamulizumab, only 16% for vorinostat. In the blood, the overall response rate for Moga was close to 70% versus only 18% for vorinostat. In the lymph node, the overall response rate for Moga was 15% versus 4% for vorinostat, and there are really few patients in the viscera. So, but I think I want to stress the particular and peculiar characteristic in terms of activity in the 3 different compartments of mogamulizumab: skin, blood, and lymph node. I think is fundamental in a disease like mycosis fungoides and Sézary syndrome. And this is the waterfall plot. I'm sorry, the reduction in median SWOT score by study in the Moga patients and the Vorinostat patients. And you can see the real difference in terms of reduction of the median SWOT. And in terms of toxicity, the most common side effects related to mogamulizumab is the infusion-related reaction observed in at least 30% of the patient, with drug reaction in at least 25% of the patient, and diarrhea in no more than 20-22% of the patient. So, but anyway, in terms of grade 3 or more adverse event in the mogamulizumab, this kind of adverse event were ranged between 0 to 4.3%. And in the Vorinostat, grade 3 or more adverse event ranged between 0 to 6%. So there is no real important hematological toxicity when you use mogamulizumab. The only problem could be thrombocytopenia in no more than 10% of the patient, with really few patients with grade 3 or 4 or thrombocytopenia. The real problem could be infusion-related reaction and drug reaction. So I think it's a very well tolerated drug. And this is like of a post-hoc analysis that they presented the last year at the international meeting. And now we will finish in the next few months and we'll try to submit for a publication. And I think these are really interesting data. So the first slide is a evaluation of Vorinostat and mogamulizumab in terms of patients in the different early and advanced stage according to the number of prior treatment. And you can see here the stratification of the patients with Vorinostat Moga. And for example, in the Moga arm, there were at least 24% of the patients considered heavily pretreated, that they received at least 6 or more prior regimen of treatment. And the median number, as I said before, was 3 for both arms. And another important point is the response and the overall response rate with mogamulizumab and the median progression-free survival with mogamulizumab is the different subset of patients according to the number of the prior treatment. You can see here that the median progression-free survival is absolutely relevant in all patients independently by the number of prior treatment. Also, in a heavily pretreated patient, the median progression-free survival was more than 8 months. And the same situation for overall response rate. So you can see the overall response rate was more than 30%, more than 40% in patients who received 3 or 4 prior treatment respectively, and in particular in heavily pretreated patients who received more than 6 or more than 6 prior treatment. Anyway, the overall response rate was 30%. Another important point is the overall global response by immediate prior systemic treatment. So with ROMI, after ROMI, the overall response rate was close to 40%. After methotrexate was 30%. After interferon was 30%. After conventional chemotherapy was 27%. After bexarotene was 20%. After extracorporeal photophoresis was 25%. There is no difference. It's active, mogamulizumab independent by the prior systemic treatment. And the same situation in terms of duration of response by immediate prior systemic treatment. So you can see that the median duration of response is good in all the different subsets. In patients pretreated with ROMI, with methotrexate, interferon, conventional chemotherapy, bexarotene, and extracorporeal photophoresis. So you can see the data is ranging between 9.4 months until 14 months. And this is the global response rate, but exposures quartile. So the response can increase when there is a major exposure of Moga. This is very important. So there is a conversion rate from stable disease to PR, or from PR to CR, according to the duration of the treatment, the exposure to the treatment. And this is another important slide concerning the clinical benefit rate. So roughly 47% was the clinical benefit rate in the lowest exposure quartile. And we had roughly 96% in the highest exposure quartile. I mean, patients treated with mogamulizumab for more than 1 year. And of the patients who had the best response of stable disease, 44% received at least 6 months of treatment with mogamulizumab. And now I have the cases that we did this kind of publication, a case report we published a few months ago. You can see on Mediterranean Journal of Hematology Infection Disease. As I said before, we treated more than 20 patients. We included more than 20 patients in the Maverick study, and this was one of these patients. The Neusers-Felder-Cesare syndrome in 2011. This is the summary of prior treatment line: CHOP, extracorporeal photopheresis plus bexarotene, total skin extranodal radiation, extracorporeal photopheresis again with bexarotene, and also conventional polychemotherapy, including gemcitabine plus oxaliplatin. Patient was enrolled in Mabry in July 2015. So these patients received 5 prior systemic treatment before to be included in the trial. And the patients, the lady started with mogamulizumab, and the treatment continued for at least 2 years until October 2017. The treatment in this case at this time was stopped because of non-lymphoma skin plaque, was a toxicity. So she had 2 years of mogamulizumab, and you can see here the impressive result in terms of baseline and after 10 cycles. And now the patient is in continuous complete response after more than 3 years. It's a fantastic result. It's quite rare, as I said before at the beginning, to obtain a continuous complete response and to try to cure this patient. But this situation is quite interesting. So you have a patient with a heavily pretreated Sézary syndromes that after mogamulizumab obtain ACR and is in continuous complete response after more than 3 years. I have a few slides concerning other 2 new treatment in phase 1, phase 2 study. The first one is monoclonal antibody anti-KIR 3DL2, and there was a phase 1 study, in particular in Sézary syndrome, with very interesting data, and the basis of that there is this new ongoing trial called the Telemark. It's an open-label, multi-cohort, multi-center international phase 2 study evaluating this new anti-KIR monoclonal antibody alone or in combination with chemotherapy in advanced T-cell lymphoma. And this is the name of this new monoclonal antibody is Lakitama, and is an anti-KIR3DL2 with the activation of NK cells that can kill the primary Sézary cells. This is an activation of this situation in vitro. And you can see some example of expression of this antigen on the patient with mycosis fungoides and also Sézary syndrome. The expression is roughly 50% mycosis fungoides and close to 90% with Sézary syndrome. And these are the data of the phase 1 study, including advanced cutaneous lymphoma, in particular Sézary syndrome, patient pretreated with at least 2 or more than 2 prior systemic therapies. And the recommended phase 2 dose was at the end of this phase 1, 750 milligram intravenous administration, with the most common adverse event peripheral edema and fatigue. And in terms of response, the global response was 43%, including overall response and CR rate. The median duration of response was close to 14 months. And the median progression-free survival was close to 12 months. So on the basis of this data, as I said before, there is this new phase 2 study called Telemark, including mycosis fungoides, Sézary syndrome, and peripheral T-cell lymphoma, all relapsed refractory, treated with this new anti-Pier monoclonal antibody. Thank you very much for your attention.
New drugs. So I think we have a couple of questions. I will start with the first question. What is the maximum duration for oral MTX, and how to monitor for side effects for patients who are receiving MTX for many years? Many of us, they're using MTX as salvage treatment weekly, and it has, of course, toxicity. What's your comment on that, Prof?
So I don't know. I don't know how is the situation in your country concerning the use of oral methotrexate, because the real problem is that it's not active. If you remember the comparison in the Marovic trial, in the Alcanta study, between the study arm and the control arm, including in this case methotrexate, the results were really poor. And in our hands, and in particular we are our dermatologist, so we decide to reduce the use of oral methotrexate in really few patients. Anyway, the problem the maximum duration could be, you have to decide patient by patient according to the response. And the problem is that, as I said before, the response is really poor, and so you have to stop the treatment after few weeks or no more than a few months, and to move to another treatment. At the same time, the side effects could be some skin reaction, and sometimes some autoimmune problems, in particular on the skin, and could be also in a few patients thrombocytopenia.
Okay, thank you. The next question is by Dr. Ahmed Al-Askar. Would you use Moga, and would you repeat it upon disease progression? Repeat using it?
So the concept of retreatment is an interesting concept in hematology. There are no data so far. There are no data concerning the retreatment with Moga mulizumab. And we discussed with the company why not to do a small trial in terms of retreatment, because could be a very good option. Because in particular in Sézary syndrome, as you saw in my presentation, the activity is very good.
Okay, another question from Dr. Adil Al-Khayti. He would like to hear something about panniculitis, like subcutaneous T-cell lymphoma.
This is a peripheral T-cell lymphoma.
Yeah.
This is a really rare peripheral T-cell lymphoma in terms of classification of WHO, and normally the conventional treatment in front line, for example, is CHOP or CHOP according to the age, and with the consolidation with autologous stem cell transplant. That is a really bad disease. It's a rare disease, but at the same time, it's so difficult to treat with conventional chemotherapy. And of course, being a peripheral T-cell lymphoma, when there is a relapse refractory situation, the treatment are again brentuximab vedotin if there is a CD30 expression or in some clinical trial. There are also some experience concerning the role of Moga in peripheral T-cell lymphoma. For example, there is an official indication in Japan, and also there are two publications, including also some patients with panicolitis, one from Japan and now another one from my center, because I did a phase 2 in a few European countries. And the rate of response with mogamulizumab in peripheral T-cell lymphoma is close to 30-35%. But I mean, panicolitis like cutaneous lymphoma is a peripheral T-cell lymphoma, and we have to follow the guideline for peripheral T-cell lymphoma. Of course, when there is a relapse, you can try to use brentuximab or also mogamulizumab.
So now a question, as you mentioned, brentuximab or mogamulizumab in patients. Imagine we have a patient who's CD30 positive. He is a young patient and he is relapsing now. What's your preference, BV or Moga?
Well, it depends by the patient. So because there is no, you have not to follow a sequential treatment. So if you come back to the data, for sure, in Sézary syndrome, you have to use mogamulizumab because there are very interesting, very important data concerning the activity in all three compartments, and also the overall response rate is very good. And considering the bad prognosis of Sézary syndrome, also the median progression-free survival is good, the median duration is good, in particular independently by the prior treatment, or independently by the number of prior treatment. At the same time, there are no data concerning the role of brentuximab vedotin in Sézary syndrome. So, in fact, in the Alcanza study, the inclusion criteria for the histology were only for mycosis fungoides and for primary cutaneous anaplastic cell lymphoma. In mycosis fungoides, the data, if you check with the two different trials, comparing the two different trials, Alcanza versus Maverick, the overall response rate is a little bit better when you use brentuximab vedotin. But the problem of the overall response rate is very good because it's 50-55%. When you compare with 25-30% of overall response rate for mogamulizumab. But at the same time, you have to remember that the median progression of survival and the median duration is quite short in when you use brentuximab vedotin. So
exactly. I mean,
evaluation according to the histology and according also to the natural history of patient in terms of prior treatment, which is the best drug to use at that time.
That's very important. I mean, the Alcanza trial, the population of patients is a little bit different than the Maverick trials. And the Alcanza, as you mentioned, T-cell lymphoma, any T-cell lymphoma, and CD30, of course, positive, and the overall response rate was 36%. In comparison with 28% for Moga. But the median progression-free survival was quite interesting and longer than in Moga, 16.7% versus 7.7%. Again, the population of patient here is very different, and thank you for emphasizing this, Prof.
The classical problem is difficult to compare two trials.
Exactly. Yeah.
Anyway, another important point is that no more than 50-60% of all mycosis fungoides are CD30 positive. So for this reason,
Yes.
in patients CD30 negative, there is no way we have to use mogamulizumab because brentuximab is not active in this. And at the same
So
time,
here,
follow the data, you have to use brentuximab vedotin only in patients who are CD30 positive, but with a level of CD30 positivity of 10% or more.
yes. Okay, thank you. Here's another question. A patient who received first line, and assuming that he is receiving now Moga Zuma in the second line, what's your preference to give in third line or fourth line?
Clinical trial this time.
If we don't, yeah, this is always a good answer. But if we don't have a clinical trial to include such patients, what would you do?
Could be if it's a mycosis fungoides, could be Chelix.
Okay. Okay, good. We have other drugs. I mean, we have.
Drug is quite active in advanced relapsed refractory mycosis fungoides. There was a paper a few years ago published by Jammer from Switzerland, and sometime I will use Chelix. It's not so toxic and is quite active in this kind of situation.
Good. Next question. I think we'll take one other question, and thereafter we'll end the session. How much CD30 positive malignant cells do you need to consider PV in cutaneous T-cell lymphoma? This is, I think, a general question for all T-cell lymphoma. Which percentage of CD30 would you consider, this patient is eligible for BV?
Okay, so this is a very interesting question. Before the phase 3 study of cancer, there were two phase 2 publications, one from Dr. Kim from Stanford, another one from Madeleine Dubish from MD Anderson, concerning the role of brentuximab vedotin as a single agent in the treatment of relapsed refractory mycosis fungoides, with few Sézary syndrome but without result. And there was the demonstration in this phase 2 study that the activity of brentuximab vedotin is independent by the percentage of CD30 positivity. I mean, there were some response, in particular partial response, also in patients with a CD30 positivity of 1%, 5%. And the problem is that in the cancer study, as I said before, the inclusion criteria said at least 10% or more of CD30 positivity. Anyway, I don't know in your country, but EMA, so the European Drug Agency, said you can include patients CD30 positive independently by the cutoff of 10% in the real life. But you can use because it's active when it's CD30 positive, the activity is independent by the percentage of CD30.
Okay. Maybe the last question again from Dr. Ahmed Al-Askar, which is really very interesting question. Where do you see the future of Moga? I mean, the approval is for relapse patients, and for relapse patient, where do you see it? In the second line, in the third line, or maybe do you see it coming in the first line as well?
Yeah, the next steps for mogamulizumab in the world of cutaneous T-cell lymphoma is, first of all, could be the modality of combination we discussed it several times, and probably we can start with a trial combining mogamulizumab plus lenalidomide in peripheral T-cell lymphoma, but also in cutaneous T-cell lymphoma, because there are some activity of lenalidomide. So to try to have a chemo-free regimen to combine one monoclonal antibodies with one immunomodulant. Another option could be to move from the right to the left, in second line, using mogamulizumab also after the conventional treatment that normally we are using at the beginning of the story of a cutaneous cell lymphoma. PUVA or plus steroids or PUVA plus bexarotene. And then the next step could be mogamulizumab instead of the conventional chemotherapy like gemcitabine or GEMOX. So we have to try to move, if it's possible, very close to the diagnosis when we have an advanced disease, from the stage 2B until to stage 4B, because it would be easier to increase the clinical benefit of these patients.
Okay, thank you. Maybe a burning question for me. The patients with cutaneous T-cell lymphoma, they are living really in a depression, because not like other lymphomas. You can see the skin of the patient, especially those who have this in the face and in the arms, etc. They are living isolated. What's your experience on gaining or improvement on the quality of life of such patient treated with Moga or BV, or would you consider, because I think it's essential for such patients. I have few patients who really very isolated.
Yeah, thank you very much, Professor Dada, for this very important issue, because it's quite easy for a patient with a CLL with a very high number of lymphocytes, but it would be really difficult for a patient with mycosis fungoides or Sézary syndrome every morning to see the face, and it could be very difficult to have a normal life, to go outside, to go to the job, and so on. And I think, and in particular, in both studies, Alcanza and Maverick, one of the second endpoint was quality of life. And in both studies, the quality of life was absolutely statistically significant advantage of the study arm. Brentuximab for the Alcanza and mogamulizumab for Maverick, because this is fundamental for the patient, fundamental. Because when we have a response, you can change the life of this patient. You can really change physically and psychologically the life of this patient.
So, okay, I think there is no more question. Anything from the organizer to be said here? I think we would like to appreciate the sponsorship of Kiona Kirin for supporting this meeting. We would like also to thank the SSBMT team for organizing such a series. And we would like to announce the upcoming webinar, which is going to be on multiple myeloma, how I treat multiple myeloma. Professor Kumar, very known, will speak about the value of how to manage patient after autologous stem cell transplantation. And Dr. Damlaj will report on the role of brentuximab vedotin in high-risk patients post-autologous stem cell transplantation. With that, I would like to thank the attendees for being with us this evening. And thank you, Professor Pier Luigi Zinzani, for joining us and giving us this very interesting talk and answering the question from your very well experience. Thank you very much, and see you next time. Thank you.
Thank you very
A
much,
nice
Professor
evening.
Thank you, Professor Alaska, and I want to say everybody the attendance. So thank you.
Thank you
a
very
lot.
much.
I hope
Bye-bye.
to see you next time in presence, not by webinar.
Hopefully, corona-free, in like a corona-free world.
Okay, bye
Thank
bye.
you. Thank you,
Bye.
Dr. أحمد العسكر. مع
Okay.
السلامة. أمان الله. مع السلامة. جزاكم الله خير.
شكرا لك.
السلام. السلام عليكم.